I was incredibly inspired by my dad's spirit during his cancer journey. But the truth is, he was getting me ready. Welcome to Spirit and Truth.
Dr. Patel, thank you so very much for lending me your time. I know you're crazy busy. You're a doctor and I'm just a guy. So,
Not at
so
all.
I,
Not at all. It's my pleasure, Kipper. It's my pleasure to be on with you.
oh, thank you. So this is my next age podcast, and I am describing my journey with this whole prostate cancer issue. And to share with people, hey, I don't know, it could help someone along the way, and that's my ambition, is to maybe help somebody who else who was also going through this. Um, so again, thank you so much for your time, and I appreciate it.
Absolutely. You're welcome.
So let's jump in. So I met you when my urologist, Dr. Arojo, um, said what she said, and I say it differently. I tell everyone I never said that I have this issue. I say my prostate has cancer, and I have to deal with that. I know that words have power, so I speak things as I'd like them to be, as opposed to, the regular nomenclature. I met you then, and she had suggested, because of my age and where the cancer was, that I should have surgery. That surgery was my best option, and then there could possibly be some radiation. She said, but you have to meet with the radiology oncologist, which was you, and you kind of said the same thing. And then we did the bone scan, found out that it was localized to my prostate, and that's what we did. So
before we dive deeper, here's a quick throwback. This B-roll is from June 15th, 2022, right after Kipper met radiation oncologist Dr. Sagar Patel at Emory. You'll hear Kipper explain how his 2 hip replacements narrowed the radiology options and why he and his team decided surgery was the best path. Let's roll the clip.
Yep, so Santa Claus pajamas in June. Had the meeting with the radiology oncologist, Dr. Sagar Patel, today at Emory, and we discussed all the radiological options that were open to me. All of them weren't, interestingly enough. And that's a whole nother movie. But because I have both of my hips replaced, for some reason, two of the options that I probably could have had, I would not have been able to get. However, after the consultation, Dr. Patel and I both agreed with the initial call by Dr. Arojo, my urologist, that surgery would probably be my best option. And so I have decided that is what I am going to do. And we'll be scheduling it, and hopefully it'll be sometime soon so we can get on with the whole recovery road. We'll talk about all of what that entails and what the ramifications are of all of that. But that's where I am on today, June 15th, 2022. All right. Thank y'all. Love you. Bye.
We're back with Dr. Patel. Kipper digs into how clinicians decide between surgery and radiation.
can we kind of talk about that? How you come to that
That decision.
information, that
Yeah.
decision. Yeah, yeah,
Yeah.
yeah.
Right. Yeah. So that's a great question, Kipper. And probably the most common one I get in my clinic when I see a new patient, a young man with newly diagnosed prostate cancer. The first step we always do, and every patient out there who should do, is first you need to assess, is it localized within the prostate or is there a chance it's spread out? 'Cause that's the most important decision tree we have. And imaging and tests have gotten a little bit better, should I say, than when you were going through your journey, Cooper. We've had a little bit new advances in imaging, which I can talk about if that's interest to anyone, but just
Sure.
special scans that help us assess. And it's a scan you got after, you ultimately got, but we do it more in the beginning setting for a lot of men during their journey. So that's the first step, which of course you did. And let's assume it's localized within the prostate. Then every man and their families and their network have a decision to make whether they want to do a surgery and take the prostate out, or keep their prostate in and do a course of radiation therapy. And that decision is very individualized. It's tailored to the specific individual, and the kind of things we consider when recommending one versus the other's age, their overall health. Do they have major medical problems? Could they deal with the 4 or 5 hour surgery? Their weight and BMI, their body mass index, and their just general fitness, which kind of aligns with those other criteria. And so when we met you, Kipper, not to disclose your stuff, but you're a young, healthy man. I mean, you look great, right? So we felt like you would recover and do well with a surgical procedure. Now, that's not the case for a lot of men. You know, we have men who are comorbid, meaning they have other medical problems, or they're older, in which case an operation just wouldn't make sense because they just would have a very difficult time recovering. And so we tend to avoid surgery and do radiation. So that's usually how we decide one versus the other, which really just is individualized based on a man's health status, their performance status, their medical problems, and their fitness at the time of diagnosis.
Got you. Now, you were saying that there are new screening methods.
Yeah, it's really exciting field for prostate cancer because, I mean, prostate cancer, fortunately, is one of those diseases that's extraordinarily well funded because it's so common in the United States and across the world, but especially in the United States. So every year we have advancements, and the biggest advancement we've had recently is developing specialized imaging to detect prostate cancer throughout the body, and that's called a PET scan, but it's a unique PET scan called a PSMA PET scan. And this is very important for men with prostate cancer to know because we used to do it only in settings when the cancer was coming back, where you had first treatment, your PSA came back, we'd get a PET scan. But now we're doing it in the very beginning. When you have a new diagnosis of a prostate cancer and you have a high Gleason score or high PSA, then we get a PET scan in the very beginning, which has revolutionized our staging in our ability to identify men with localized or advanced cancer.
That's awesome. Just because I mean, my diagnosis was just a little more than 2 years ago, and here we are already having these advances in technology or in treatment.
That's right. Yeah.
I think that's awesome.
Yeah, Kipper, because your story is kind of on the cusp. I think your story lends and gives credence to the rapidity of prostate cancer advancement. Just in a few years, we can have different staging or management paradigms, and that just speaks to the advancement of the field, really.
Wow, that is awesome. So I've noticed that in a couple of my support groups, there are people in the early stages of their diagnosis and that kind of thing, and they're weighing out their options about surgery or radiation. A lot of them are younger, and younger all the time. I just met a Hispanic young man who was 39, which really kind of shook me because you hear so many treatment or testing recommendations for 40, and that kind of thing. And so I'm actually telling people, hey, and especially men of color, get tested early. Get tested at 30. It's not going to hurt you. It's a blood test. So what do you think about the testing parameters and that kind of thing?
Yeah, great question, Kipper. Probably one of the most controversial questions we've had in our field over the past decade. Let me briefly shed light to individuals on why there's controversy, because your rationale makes complete sense. Hey, it's just a simple blood test. Let's see where we are. Do you have an elevated PSA or not? And if you don't, great, move on. If you do, then you can follow up closely with that. The reason why it's been so controversial over the past decade is because we were overdiagnosing men in the early 2000s. When the PSA test came out, we were testing every man and their dads and sons in the clinic. And we were identifying prostate cancer that probably wouldn't doesn't need to be diagnosed. And it was resulting in a lot of unnecessary surgery or radiation and treatments that caused, toxicities, as you know intimately, and side effects and cost to the healthcare system. So the U.S. Preventive Service Task Force in 2012 advised a grade D recommendation against PSA screening. So all these primary care doctors around the country were essentially de-incentivized and told not to do routine PSA screening because of just the epidemiology and just the healthcare expenditures that were current. And then from 2012 to 2018, we started unfortunately diagnosing men at more advanced stages, as you can imagine, because we were not screening these men. So in 2018, the U.S. Preventive Service Task Force reversed their recommendation and basically left it open-ended that you should have a discussion with your doctor and decide for yourself. So that's where we are today. It's an individualized choice, but Kipper, to your point, I think men of color, of ethnic regions, Hispanic Americans, African Americans, Black Americans in general, should undergo screening earlier. I recommend at 40, especially if you have a first degree relative who's been diagnosed with prostate cancer. For example, as a man, if you have a father, an uncle, a brother who has been diagnosed, you should be much more vigilant about screening. For white Americans, it's a little bit more open-ended. Current guidelines suggest around 45, you can do an initial PSA, but I think Black Americans, certainly 40 should be a cutoff, in most, especially if you have a family member who has been diagnosed with prostate cancer in the past.
Yeah, I mean, which was my experience with my dad. My dad had the genetic testing done and found out that he had Lynch syndrome, which was that defective gene situation, which is a very highly genetic, right? I mean,
Right.
hereditary.
Uh-huh.
And so you're speaking to me, right?
That's
Again.
right. That's right.
Um, so also the PSA levels, 4 or under, I know was the parameters or whatever that they gave when I was tested. But now I'm even hearing maybe even lower. So what are your thoughts about
Yeah.
that?
So we take PSA all in context of an individual. So let me give you two examples, two very different men in my clinic and how I would respond to their PSA. Let's say I see a white American in my clinic, 47 years old, no family history of prostate cancer. They get a first PSA. It's 2.9. I won't think much of it. I would just follow them, maybe get a PSA the next year. It's 3.1, no concern at all. Now, let me give you another example of a 47-year-old Black American whose dad was diagnosed with prostate cancer, who has a PSA of 2.9. I'm a little bit more vigilant. I get a PSA the following year, but if it's gone up to let's say 3.2, 3.3, I'm even more vigilant because there's been 2 data points that shown a rise in a Black American who has a first degree relative with prostate cancer. So I may get a PSA 6 months later. And if it's continuously rising, I may get an MRI. So I'm going to get subsequent measures as opposed to just saying, hey, we'll watch you every year. So those are the context of an individual that dictates how vigilant I am based on their PSA. So I agree with you, Kipper, that 4 is a bit of an arbitrary cutoff. It may not be 4, it may be lower, but it depends on the individual's risk factors and then their kinetics or the way their PSA trajectory is going.
Got you. And again, for everybody, PSA is prostate specific antigen, correct?
That's right. That's exactly right.
And that's the, look at me. So that's the what PSA stands for and the measure by which they calculate that. So and I want to say thank you, first of all, for being culturally specific. I think that in the medical field, there is a lot of reluctance, hesitancy, and especially when it comes to African American men. Black men have a certain hesitancy about the medical profession anyway, because of things like the Tuskegee experiment and Henrietta Lacks and all of these other sorts of medical atrocities, shall we say. So to hear you say that is, I'm sure, very comforting to a lot of people that may see this. So I want to just say thank you.
Oh yeah, no, I appreciate you. Let me touch on that. One thing I'm very sensitive to, and really motivates me to make sure we disseminate our knowledge to perhaps communities that are not who perhaps are a bit distrustworthy to the medical center for legitimate reasons like you just gave. What we found in studies, and the reason why we are a bit more vigilant around prostate cancer for African American men is that we found that African American men, especially in the United States, are more often diagnosed with aggressive prostate cancer and potentially lethal prostate cancer. But
Mhm.
we've also found is that the same men who get treatment compared with non-African American men, for example, white counterparts, they do better with treatment. So the
Mhm.
disparity I'm seeing in our country is perhaps it's an access to care for Black men to achieve the same equitable outcomes that we want to achieve. So I think that's really compelling to me. So we just need to get our outreach, our medical care out to the community so men are screened, men are diagnosed, because with treatment, they can do just as well, if not even better. So that's an important piece of data that I share with patients when I see in the clinic.
So lately, in our social space, I mean, we've seen O.J. Simpson, Dexter King, and most recently, musician, a friend of a lot of us, David Sanborn, who are all prostate cancer victims. I'm and knowing my journey and knowing that prostate cancer, like you said, is probably one of the most treatable forms of cancer. Um, I don't know, why is it that uh, we're finding like these advanced cases this way? And and then because I think the comment about David Sanborn is that he passed from complications due to prostate cancer. I mean, I mean, I know my journey. I can't say for anybody else, and I know everybody's journey is individual to them. But what could complicate things
Yeah.
to that degree?
That that's a great question. I think this is a good platform to discuss that. At least share with you my thoughts on that because
Mhm.
individuals like yourself and my own family members who aren't necessarily in the medical field, especially not in the prostate cancer field like me, will hear that and say, "What in the world? Is it the treatment that's causing it? Is it the medical interventions you're causing, or what complications are you talking about?" So that's a really important question we highlight that I'd love to comment about in this venue.
Mhm.
Typically, when we use complications of any cancer in a patient passing, my interpretation is typically that cancer became very advanced, metastasized, became refractory to treatment. And usually a man passes from prostate cancer because the cancer has spread to vital organs, like throughout the bones that debilitates their bone marrow and causes bone marrow suppression and risk of infection. And then they get an infection and die
Mhm.
or it metastasizes to the lungs and causes cardiopulmonary arrest, and then they pass. So that's usually how we interpret complications because it's not from the prostate cancer in the gland, it's from the metastases that go to other organs that cause secondary complications that then result in a man passing. So that's typically the reason why men with advanced prostate cancer unfortunately die. And I believe that's what colloquial terms they use complications from the disease, not necessarily from the hormone therapy or the chemotherapy or the treatment, but more that the metastases have spread to vital organs and cause secondary issues that lead to death.
Now, is that because of late treatment or
Typically, yeah, Kipper, yeah, that's right. I mean, prostate cancer can be controlled and kept at bay even for men diagnosed with metastatic disease. But if you diagnose it too late, meaning if your first time diagnosing it is with cancer spread throughout your bones, we can
Mhm.
keep it in bay and check for up to 5 years or more. But ultimately, that disease will mutate and become refractory to our standard treatments, in which case it will inevitably, with time, take its course and potentially lead to death.
Wow. So my initial diagnosis was highly advanced, I want to say, because my PSA was 20 when Dr. Arojo first, alerted me. Um, that how is that on the spectrum? I mean, is that late in diagnosis or?
No, yeah, no, it's a good question. I think on the spectrum of localized cancer, like which of course, like as you shared, we found out you had in the beginning, it's a
Mhm.
little bit in the higher, but no, when I talk about advanced, I mean, this always throws off my patients and listeners. I mean, I'm talking about PSAs up in the five, 600s,
Wow.
thousands. which, yeah, it's remarkable how high the PSA can go. But when a man's diagnosed with very advanced disease, we see PSAs up above 400, up to the thousands, which I know it's remarkable. But that
That's
just tells you how much cancer burden an individual would have in their body at the time of potentially being lethal.
That's alarming.
Yeah.
That is just alarming.
Yeah.
Okay, so I know I don't have you for a long time, but I have a couple more questions.
Please. Yeah.
When in terms of, because I did the surgery and then you, like you said, there could be a chance I would have to do some radiation if my numbers weren't undetectable, and they crept up 0.14, 0.27, 0.56, and we knew we were going to have to do the radiation piece. So kind of explain what the radiation does and what, how that then is the treatment, the desired treatment, and why
Yeah, yeah,
and why.
absolutely. And for any listeners who may be going through starting a prostate cancer journey and may be pursuing surgery up front, I think this is really important information to listen to, or even if you're trying to decide to do surgery. So, anytime a man gets surgery for prostate cancer, even when we recommend it, there's about a 20 to 40% chance their PSA will creep up. Kipper, just like what happened with you. And
Mhm.
that's not anything about the discount to surgeon. It's just because our male pelvis is like an ice cream cone. That's how I kind of describe it to patients in the clinic, that our pelvis is like the ice cream cone and the prostate's like the chocolate sitting at the bottom of it. So even with the most skilled surgeon in the world, it's really challenging to go in and scoop out the chocolate and leave the entire cone intact. So inevitably, some chocolate gets left behind, some prostate cells get left behind. And typically, that will declare itself with the PSA 6 months, 8 months, a year and a half after surgery. And for example, that's what happened with you. So when that happens, the first line treatment is doing radiation, what we call salvage radiation, where we attempt to recure you with a course of radiation to the pelvis. And the reason why is because there's microscopic leftover disease in where the prostate used to sit before the surgeon took it out. And the radiation essentially treats that entire space to sterilize and kill off those cells. So that's the basis of doing radiation after surgery. And like I said, up to about 20 to 40% of men on average would need radiation after surgery for that reason.
And when we talk about the surgery, again, it was a laparoscopic procedure, laparoscopic and robotic, right? So
Mm-hmm.
there's, you say surgery to some people and they immediately think, Jason and Friday the 13th, and it's not that.
Absolutely. I mean, you can attest to this through, and I'm sure you have shared in your own journey. I mean, the minimally invasiveness of the surgery now, it truly is minimally invasive. And we're talking about tiny little incisions in your abdomen, tiny little probes placed through the abdomen, and then that's it. And then the robot is exquisite on being able to remove the prostate without cutting your stomach open, like some individuals may imagine.
Yeah, or as probably in
It,
generations past, or
exactly. That's
yeah,
right.
yeah. So okay. Let's see here. We talked about the age, we talked about the diagnosis and all of that kind of thing. So just from a medical standpoint, in terms of options, because you kind of spoke about it a bit, but I've heard everything from seed treatments to just the radiation, or just this. I mean, just, I guess it all depends on what the person, who the person is, and where they stand and all that kind of stuff. But what are like the total maybe range of options that you would have after
Yeah.
diagnosis?
Yeah, that's a good question. And well, let me share kind of in a bird's eye view, broad overviews, just so at least any listeners can feel empowered to ask more detailed questions to their doctor. But like we talked about initially, about 15, 20 minutes ago, initially, once we know that a man's prostate cancer is confined to the gland, which frankly is a majority of men who get diagnosed with screening detected cancer, they have a option of either surgery or radiation. Surgery, there's basically one standard of care: robotic laparoscopic assisted prostatectomy. Um, so that's the standard. For radiation, there's a whole menu of options. And let me briefly kind of give some terminology of what's available. We have external radiation, where we use sophisticated machinery, like where we deliver radiation beamlets from a machine into the body, it doesn't burn, sting, or itch. It's painless. You lie on a table and the machine does its work. That's called external beam radiation. We have internal radiation where we implant radiation directly into the prostate gland. We have seeds, which is a type of internal radiation where we implant seeds into the prostate. We have temporary seeds, which is a technique I do a lot, where we put the seeds in and then take it out same day so patients don't leave my clinic with radioactive material. Then we have other forms like proton therapy, which is also something I specialize in, where it's a form of external radiation, but instead of using standard X-ray radiation, we use proton beams, proton particles that in effect treat the prostate, but it's a bit more precise and focused and confined. So it reduces the radiation exposure to the body. And then finally, in 2024, we are able to give big doses of radiation in a short amount of time, where historically radiation needed to be 9 weeks. And that was, as you can imagine, very difficult for patients to sign up for. But now with advancing technology, we can do that same treatment in just 5 treatments, where a patient comes in 5 times and gets their prostate treated in 5 heavy doses. That's safe and effective because of our technology. So that's just a flavor of the different options that are available for a new prostate cancer patient. And I think that how we determine one versus the other is a factor of age, their medical history, their comorbidities, and also their prostate gland size and their urinary function, how frequently they're going to the bathroom, how many times they wake up at night to go to the bathroom, how much urgency they have during the day. Those types of questions we ask in the clinic to help us determine what the best treatment may be for that individual.
Which was a major indicator for me, that whole frequent urination piece. There was one more thing that I want to forget, but the hormone therapy piece.
Yeah.
Because prostate cancer feeds off of testosterone, right? And so if you want to speak to that, because I'm even though I'm 2 years out after diagnosis, after surgery, after radiation, I'm still having some hot flashes. I'm still, not, erectile dysfunction is still part of my vocabulary. So.
So hormone therapy, I think in the whole spectrum of treatments, is the least favorite aspect of any man's journey with prostate cancer, but it's an important backbone of treatment. Now, not every man needs hormone therapy. Only men with higher Gleason scores or cancer that's disseminated outside the prostate need hormone therapy. And just to give the basis, Kipper, just like you nicely outlined, testosterone is food for prostate cancer. Cancer grows and thrives off testosterone, which is our male hormone. So we know that drugs that suppress the testosterone kill and put the cancer cells in hibernation and starve them to death. So it's a very good treatment for prostate cancer. But when we suppress an individual's testosterone, we can make them feel lousy, which causes side effects like some fatigue, erectile dysfunction, decreased libido, and hot flashes. They're no fun for any individual, but they're so important for managing their prostate cancer. Now, we're making advancements every year in terms of managing those side effects and or developing new hormone drugs that suppress the testosterone but mitigate the side effects. So every year we seem to be making advances in the drugs, but the cornerstone of suppressing the testosterone, for better or worse, will remain a backbone of treatment for a big proportion of men who are diagnosed with prostate cancer.
And it does come back.
Very good point. Very good point. And I think that's really important to repeat for listeners, that if you require hormone therapy, it's a transient suppression, hopefully. Meaning you get treated with hormone therapy, you deal with the side effects, but once you're done, your testosterone will slowly recover, in which case you'll feel better. Hot flashes will just slowly spread apart, disseminate. Your libido will rise. Hopefully erectile function gets better. So those side effects can improve once you're done.
Indeed. Dr. Patel, thank you so much for your
You're
time.
so welcome.
I know you got stuff to do. So
No, I want to catch you, man. This opportunity I couldn't say no to. You're such a dear patient to me. I loved our interactions day to day when you're on treatment. You're a trooper, man. I think I told you this when you're on. I mean, you're so active with your life. It's so awesome to see you host this podcast, and you're such an active man with a huge community network. But you took the treatment in stride, man. And you're my poster child for being a prostate cancer patient. I love that you have an avenue to share your wisdom and knowledge, because you have a lot to share, man. And I was so proud of you during treatment. And like I said, I couldn't say no to an opportunity like this. So thank you for having me.
Well, thank you so very much. I appreciate your kind words. Thank you. And I'll see you soon, I'm sure.
That's right.
So-
I will see you very soon, man, in the clinic. All right.
Yes, sir. God bless you, man. Have a
All right.
fantastic day, and thank you again.
You got it, man. All right. Take care now. All right.
Thanks for tuning in to this episode of Spirit and Truth. You can subscribe to the show wherever you listen to your podcasts, and follow Kipper at Uncle Kipper everywhere on social media.